Well, good afternoon, everyone. We're going to go ahead and get started. John, do you feel like no one wants to sit with you? Okay. So we're going to begin. I apologize for us beginning a little late, but as everybody gets settled, we have some really good news, and that is Pablo Gaxiola. Where did Pablo, is he sitting? Just got promoted to the Director of Programs for Goodwill. That is fabulous. We're just all really excited for you, but really for our community as well. So we're going to begin. David, do you want roll call, or would you rather us? You can. Okay, you're good. Okay, great. Thank you for that. What we're going to do is we're going to call our meeting to order. We're going to begin with public comment, and we have one speaker on public comment, and we have two people on public comment. So we'll begin with Scott Largent. Welcome.
Thank you. All right. Good afternoon. Scott Largent. Recently in the Mercury News, I guess that we're no longer going to be prosecuting people over minor drug charges here in Santa Clara County. I've been watching downtown a lot, and it's great for filming a documentary about just a mental health disaster down there. I'm sorry, a meth disaster. If we're not going to be putting people in jail right now for getting high, and then we're not going to bring them in for over, I believe it's $15,000 worth of warrants, what are we going to do to help these people? Because now it just increases to a point where they just don't care downtown now. They don't care down the light rail anymore. They just don't care. And the other day when I left a meeting, I was talking about how they took over the kids' playground downtown over there, and there was, meth pipes, heroin needles everywhere. Right after I left from talking about that, I'm walking past St. James Park, and an elderly man just got absolutely beat there. Luckily enough, we were able to catch the guy kind of off to the side, and the police got there and everything. They don't care anymore. And the people that are on methamphetamines are the ones that are destroying downtown. They're destroying the light rails. They hate the bird scooters that are down there. I see them just pick these things up and throw them side to side. They punch holes in windows. They break the light rail plasma TVs that are up there. They beat up the security phones that are there. And then they just half-naked smoke meth. They put tent things over their heads. I mean, it's just very bizarre. And what I'm wondering is I don't really think it's this big mental health issue. It's meth addiction. And all I hear is you people talking about mental health, mental health. As an example, after I was off meth for a year, my brain kind of resetted and I started acting normal again. I don't believe I really have a bad mental health issue. I have ADD and ADHD. I have a learning disability. But the main part was taking the meth away from me. That was the most important part. I don't think you guys are going to be doing that anymore. I think you're going to just keep excessively billing the mentally ill and homeless with services that are never going to help them. They all need drug rehab, okay? And then after they're in rehab for 6 months or a year, then we can start to look into the fact, hey, does this person really have a mental health issue? Methamphetamines that's being manufactured out of Mexican super labs right now is making people go crazy. I went crazy after I was on it for a year. I had a shotgun in my motorhome. I thought everybody was coming to get me. I thought helicopters were everywhere. I was yelling. I was screaming. I was doing all this bizarre, crazy stuff that everyone's doing downtown. Take the meth pipe out of my mouth, that stuff stopped. And then over a year, I started acting normal. So I'm really confused with what you people are up to. So thank you.
Good afternoon. My name is Ted Scarlett, and thank you for allowing this time to speak. My concern and what I'm seeking is a vote of no confidence for District Attorney Jeffrey Francis Rosen for his custom and practice ongoing of prosecuting individuals that he knows are innocent. It's abuse of office. It's abuse of the public trust. Okay, there's several cases, including my own. I mean, Scott Largent, the man that just spoke, has been charged several times, and either charges have been dropped or a jury would not find him guilty. There's a Tanya McCash. Started out as a family court issue, a divorce. The accusation is a violation of a restraining order that was not even served on her, and the violation was going to her daughter's school on Halloween day, the day after she was in court. Okay, and subsequent to that, the daughter was not added to the restraining order until the day after the arrest. Now this has snowballed into, she's now in the drug court before Mr. Manley. And what I see here is just the attempt to totally destroy this woman. Okay, again, this is very serious. It's a custom and a practice for District Attorney Jeffrey Francis Rosen to continue to prosecute people or even initiate prosecution on people he knows are innocent. Thank you.
Thank you, Ted. We will now move on from the public comment to our consent agenda, and really we only have our minutes, so could I get a motion? Oh, I don't have quorum, okay. So we're going to move on to the Sobering Center report. This is item 4.
Good afternoon, Bruce Copley, Department of Behavioral Services, to give you a brief overview of the Sobering Center. The Sobering Center was opened in October 2017 at the Mission Street corner, just at catty corner to where we are today. It is operated by Horizon South Corporation, which has been a long-term contract agency for substance use services, providing residential services for males and detox services for males. And also they have extensive experience in Alameda County of running the Sobering Center in that county as well. When we opened the center, we started with five chairs, and we kept it to Campbell Police Department, Mountain View, and Santa Clara County, smaller jurisdictions, to better understand what the logistics would look like and what the flow might be from those law enforcement agencies. Since then, we've opened it up to include most every other jurisdiction. In January, we opened it up to San Jose Police Department, and we've expanded to 20 beds, 15 male beds, and 5 female beds. The goal of the Sobering Center was to look at an alternative to incarceration from law enforcement, but also to open it up to emergency departments, which has been used in other jurisdictions as a way to relieve the congestion at emergency departments and address issues of alcohol intoxication in a Sobering Center environment. You'll see from the list of referring agencies that it's increased significantly. It includes some universities, as well as our emergency department. Valley Homeless has utilized it. We have had some referrals from our own behavioral health services department, individuals that have gone to detox, and there have not been beds. There have been referrals made for individuals who are intoxicated to come to the Sobering Center. Also, we have opened it up to transitional housing units that are served by our county, where an individual may come back to the house under the influence. Instead of barring them from the bed, an alternative is have them to go to the Sobering Center and sober up there. The average time for an individual to spend in the Sobering Center is somewhere between 6 and 12 hours. We also have a van, and we're able to go out into the field, meet law enforcement or emergency teams and actually pick up individuals in the field and return them to the sobering center, as well as to the emergency department and pick up individuals. Where necessary, when an individual discharges, we have used the van to take them back to wherever their house is or wherever they would like to be dropped off and supported from a family member. As I said before, a sobering center is under 24 hours, so it doesn't come under any of the licensure. It allows us to stabilize individuals, do an initial assessment, look at what may be additional medical complications. Also, where they are eligible, we've been able to engage and get them into whole person care so that they're connected with health care. A number of these individuals have been referred on to the treatment system, both to the social detox as well as the residential and outpatient programs, as well as to some of the mental health facilities as well. The principal issue here is to engage the individual as they sober up through the support staff and look at how we can assist them in whatever brought them to the sobering center and what kind of social service needs they have to not have to return. Individuals that qualify for Medi-Cal are also being connected with social service to get them that benefit so that they again have an opportunity for health care and mental health and behavioral health services. When we started to look at the detoxification bookings in Santa Clara County, in 2016 there were a little over 1,600 bookings. 2017 it went down to about 1,400. 2018 it's been down to 1,200. So there's been a shift in terms of what is happening with law enforcement in the field. I can't really explain what that is, whether there's less issues now that Uber's available or Lyft is available, there are less individuals that are on the street, or it's just a change in terms of practice of law enforcement. The capacity of the system, as I say, is 20 beds. We have not reached that. We've been well under that in the 19 months we've been in operation. So we're looking at an alternative of looking at splitting the sobering center and adding a mental health triage center for, again, law enforcement to bring individuals from the community, have them be able to be assisted, and look at how we can then connect them with additional behavioral health services upon discharge from the center. In the last 5 years, there's been a significant increase in sobering centers over the nation. 3 years ago, there were 35 across the country. Today, there are over 50. So a number of communities and states have really seen this as a valuable alternative to both law enforcement and the use of emergency departments, as well as a way to engage individuals and motivate them to look to additional services so that they don't return to drinking. Let me stop there and take any questions you might have.
Thank you very much. I'm going to start on this side and see if there are any questions or comments. I'll go to Chief Garnett and then Judge Manley.
Do you guys take DUIs or just drunk in public?
Drunk in public.
Okay.
Yeah.
Judge?
You're not taking any drug cases at all?
Not primary drug use. Again, depending on there are certainly individuals coming in with intoxicated and some substances in their system, but most of the street drugs are such that a 23-hour, 59-minute stay is not going to probably address their issues. They're more appropriately placed in a detox services where they can get 3 to 5 days of support as they come off whatever their substance is.
All right, well, I noticed in your data here that of those you refer to detox, so it's obvious that a number of these individuals need detox, there's no capacity for at least 40% of them. So what is being done to increase capacity for detoxification for drugs and alcohol?
Well, Judge, we have 6 more beds that are coming online from Pathway House in their new contracts for males. And we're with the telecare operation at Muriel Wright. I'm engaged in getting 2 additional detox beds in that facility. So we'll have a total of 8 additional beds for male individuals needing detox.
And will that include drugs, or will it still
Yes,
just be alcohol?
the detox, social detox includes both alcohol and drug use. And as was mentioned by the previous speaker, many of the social detox individuals are there because of the use of methamphetamine. So they tend to stay longer, upwards of 5 to 7 days, to titrate off of the methamphetamines and stabilize enough that we can bring them into residential care.
I guess what I really don't understand is why you aren't taking drug offenders or people who need help with drugs immediately and just concentrating on alcohol. Because, I mean, I do this every day. I do not see many people who solely use alcohol. They usually are also using meth and or some other drug. And it would just seem to me, I note all the referrals you have, and maybe I'm not counting the numbers right, but as I read this, it seemed to me you're open 7 days a week, right?
24/7, yes,
All
yes,
right.
sir.
So I counted, I think there were 398, and we got 365 days in a year, and it looks to me like one person, or 1.5 people a day. I mean, why can't we expand this? I would like to see these people be referred from the court. There are many times I don't want to remand someone. I want them to go to detox. They need a warm handoff. They need help. It would be so much easier if I could send them to this center, even though they've been primarily using meth. I don't understand why we are fixated on alcohol when we have a huge problem with drugs and too many people in the streets who aren't getting the help. And I would also like to suggest that in the referral that you include the court. So I would like to be able to refer people directly from the courtroom, because I see no reason to necessarily incarcerate someone solely because they need detoxification. And that's what's happening. And the number of people who are leaving THUs and being discharged because of the use of drugs and into the streets and never back is just, it's just beyond, I can't keep count of it. It would just seem to me that there could be a much better use of this program than presently.
So let me I'm going to let you respond to the idea in just a minute, but I do just want to just kind of refresh everyone's memory about how we ended up focused on the sobering station. There were 2 big reasons for that. One was that as part of our ongoing movement to stop incarcerating people, it was actually a diversion. It was the jail, a subcommittee of this entity that really asked our mental health and our behavioral health department to look at sobering stations. I will also say that the other group we were responding to was the police agencies, who were recognizing that they were spending a lot of time and resources taking people not who were drinking and driving, but just drunk in public, and we were trying to figure out a pathway to getting them services. So really it was the jail diversion committee. The reason I mention that isn't because like none of these ideas are static, but I just wanted you to know that we all knew we had to start somewhere. I will just say one other thing. Some of our police agencies that were really interested in this, in particular San Jose PD, had a much slower upstart. I'm not blaming you, I'm actually going to blame your attorneys. Had a much slower upstart to using the facility. And in the meantime, I think the point you raised about Lyft and alternative methods to get people who were just stupid in public, giving them an alternative. And I know the police department has been trying really, I mean, I know San Jose PD, only because I talked to Eddie, the Chief Garcia about this, was telling me that they really are trying to keep people out of the system who don't need to be in any system, not with us, not anywhere else. So all that being said, we asked for a scaling up of this, not a diving in. But I also just want to now give you a chance to respond to the question and the idea. And I do know you have another idea in the document, but if you wouldn't mind.
So the national model is really focused on alcohol intoxication. Again, the experience of those individuals going into a social detox that are under the influence of a multiple number of drugs. First of all, 23 hours and 59 minutes is not going to clean that out of their system. They're still going to, a number of them will still be very much under the influence of whatever the drugs they're taking are. Second of all, detox from drugs at times can be medically complicated. And again, the Sobering Center is not a medical facility. It has a fairly high bar in terms of what an individual would have for blood pressure, and beyond that, those individuals would be referred to an ED department. So most definitely, I think we could look at another alternative for the drug problem, but I don't see the strategic plan of the Sobering Center being able to be shifted significantly towards just taking individuals that are under the influence of certain drugs.
If I could just follow up on the point that Judge Manley raised about having an alternative place for, I think his point about a warm handoff so that people could be sent to us, and then that handoff occurs since we do have professionals there. What's your thought about that idea?
Well, I think that's a good point. My understanding is that's one of the reasons we have the RRC and the mobile medical van, that individuals can come in and get a bit more of an assessment, both from a biopsychosocial as well as from a medical perspective, to better understand what their services should be in terms of both the medical side and the mental health side or the behavioral side.
I think that I see your light is on. Do you want to respond to this question?
Well, just and maybe ask a question or provide some information. My understanding is this is the Sobering Center is paid for by a whole person care grant, and my understanding is that grant says that it needs to be limited to alcohol use. But
yes, that was the application put in to have the whole person care dollars appropriated for the Sobering Center,
and limited to alcohol as opposed to other drugs. So I mean, if that's the answer, maybe we could look at repurposing, but if that's what the grant requires, we're going to have to be careful with meeting those requirements.
Yeah, I agree. And with some careful look at what are the presenting issues that would occur with someone under the influence of alcohol and or other drugs, that would help in identifying what an appropriate intervention might look like.
Do you test?
Pardon me?
Do you test? How do you know they're only under the influence of alcohol and no other drugs?
Well, the officer, if it's brought in from a law enforcement officer, there's been some sobriety tests done in the field. When they come in, they're asked to...
For drugs?
Pardon me?
For drugs.
And I don't know. I can't...
You see, we are living in a world, I mean, I live this every day, of co-occurring disorders. Alcohol and drugs run together. The person's under the influence of both. I don't understand. I guess, okay, I should stop talking. And I will concede the point. To me, the great frustration is to see all those empty chairs that I believe so much in the program. I would like to see that you would take drugs as well as alcohol because they run together, and that you would then move them on into meaningful detoxification, residential treatment. Your provider is one, I believe, of the best that I know of, Horizon South, that has taken many of our clients over the years. It just seems to me that we're spending, even if it's grant money, a lot of money, and not serving enough people.
Thank you.
Thank you.
Judge Manley.
That's
And
it.
then I'm going to go to Deputy Chief Tyndall.
Deputy Chief Tyndall for Chief Garcia. Question for you to know that we are ramping up and obviously getting more of our officers to bring and use your facility. As far as the van and the transport, is that, number one, is that 24/7?
Pardon me, sir, could you say that again?
So as far as the van, I mean, what I'm looking at is obviously minimizing police contact and police involvement and even transporting
Right.
Individuals. Is that van 24/7?
Yes, yes, and if the officer is in the field and calls and the van's available, they will come out and meet the officer in the field to pick the individual up.
And I can get with you after. Is that just through county dispatch then, or is there a specific
No,
number?
it's through the number directly to the sobering center,
Okay, I will get that from you. Thank you.
and it's in that flyer that we distributed.
Excellent. Thank you.
Aaron.
Question, with the detox beds that are coming online, what is the percentage of the unfilled need that you think those beds will fill?
I don't know. I mean, we don't have enough detox beds for a number of years. We've tried to go out and get additional vendors to provide it. It's an issue of finding space, and it's an issue of someone wanting to take on a very complicated case. So I most definitely 8 additional male beds will assist. I don't believe it's probably enough, but it's what we were able to get. More importantly, what we are really lacking now is a medical detox for some of the more complicated cases that we're getting that really will not qualify for a social detox. They need that medical oversight for some of the substances they're ingesting and having to come off those substances.
So, yes, Tony.
And we are having conversations with Paul Lorenz at the medical center about what might be a possibility. No decisions have been made, but we have had an initial conversation saying this is really the issue that we also see in EPS. And so individuals come high on meth, they get released, and they go back into the community in San Jose PD, many of your officers, pick them up once again, and they may go back to EPS again. So we're really trying, we're working very closely with EPS, and we've had conversations with Paul about what might be possible for that population.
So just a couple of observations that I want to make. And first of all, let me just say, I do know we have a couple speakers from the public. In fact, why don't I let the speakers go, and then I'll give some thoughts about how we can maybe move forward. Oh, Scott, it's just, not just, but Scott, if you could come forward. Thank you. I had 2. I see that's for the next one.
Good afternoon, everyone. It's not an alcohol problem. It's a meth problem. So I think we need to start addressing that. And I get the thing about the grant. You know, we fudge things with people's court paperwork, and we do some sneaky things in our county and our city. Why can't we just kind of make it up and just say that the person's on booze and then detox them off of methamphetamines for 5 days? Why don't we get creative with this? It sounds like we have empty beds over there, and I enjoy what Judge Manley had to say, and I don't mean anything disrespectful towards you, Judge Manley. I would like you just to continue saying what you were saying. I would like it not to be cut off. These people need to hear the truth, and it needs to be slapped in their face when it comes to this. It's been 3.5 years that I've been sober. You still cannot get into drug rehab. There's no walk-in business. You still can't get into detox here in our county and walk into a place and get it. We still can't do it, and I don't know who this gentleman is right here, but he's talking about alcohol. They're all on meth. They're all meth zombies, and every day it's worse and worse and worse, and I'm just, you know, in the private sector, you would all be fired, okay? Elected official, we can't fire, but you would all be fired. We can't have this anymore, and people aren't paying attention. How much money is going into this here? This is an absolute failure. Get on the light rail, just take the light rail down the road. It's one after the other. It's nonstop, and it's just escalating and escalating. And I don't know who, and I said this earlier, who's changing these rules for our jails right now? Why are we not able to arrest people? Now we're just going to allow them to get away with all this stuff. We have no place to put these people right now. And that place is a great facility over there. Start taking the meth addicts over there. Maybe the community wants to donate towards that over there so we can clean up things. I really want to take my daughter to the park at St. James Park. I really want this to be cleaned up. Thank you.
Thank you, Scott. I wanted to just go back to another issue that was raised, and I apologize, I don't know if this was raised in the report or just through our exchange with your office, but one of the other options that you'd been considering was taking people who were mentally ill but not EPS worthy, but that the law enforcement would have a place to take someone while we were trying to stabilize them and then potentially get them to a service. Is that something that is being considered actively now?
Actively, and it would not just be from people with mental health issues. It would totally be a co-occurring setting. And what the intent would be...
I'm sorry, what would that mean?
Co-occurring means that the clinicians are trained to deal with substance use or mental health issues.
So it would not just be alcohol, but drugs and...
It'd be whatever kind of co-occurring mental health, substance use need in a 24/7 setting that would be focused for justice-involved clients. So it would be a place for law enforcement who've been asking for this to bring people. We're telling them don't send them into jail, and they want a place to have them go so that we can connect them to services. And the idea is that we would have staff there trained on co-occurring. There'll be psychiatry there as well. And then we'll have care coordination teams come maybe every morning, maybe twice a day to really work with people and get them connected to care.
So
it's a gap.
me, this facility is still 23 hours, right? Based on our licensure, is that accurate?
It's 23.59.
Okay.
That's what it is. It's a 23. Both
All right.
of these would be 23.59.
Good to round up. So it's 24 hours,
Yes.
less a minute. Okay.
Minus 1 second.
Got it. So 24 hours minus 1 second. So, and then just to better understand that, what you're saying is that we will be accepting people who are mentally ill but aren't EPS worthy into this facility if they're on drugs and or alcohol.
I think alcohol would go to sobering, and then if they needed a setup, we'd send them over to the urgent care center.
Yeah, I mean, if I would love to come back and explain a bit more about the complications of drug detoxification to understand what we can accept there and what we can't accept there. It's not cut and dried. It really depends on the involvement of the different drugs as well as the length of time the individual's been involved with the drugs.
Got it. Well, what I'm... Go ahead, Judge Manley.
No, you hadn't finished your thought.
That's okay. You're jumping out of your seat. You're a
No,
judge.
I'm not. No, I'm not. I was
Go
just
ahead.
going, just while we're on this point, I wanted to add, since you are going to be thinking about it, about changing things, I want to suggest something that I have talked not to many people about, but I think it's very viable. We have a lot of people, and Bruce has made mention of it, who do not last in a THU because there's some very old-fashioned rules that hopefully Tony is going to work on changing. They wash out of there, they don't go to court, bench warrants issue, all of which can be recalled. My theory is this: if you are now in bench warrant status and you're just simply using drugs and not taking your medications, we should not have to book them into jail if there is an alternative. And I guess the frustration I see is that we have these empty recliners. Here's a place where we've got a concept for alcohol. We could expand that. The warrants can easily be recalled electronically, and we could avoid this process of repeatedly cycling through the jail. They could be re-engaged in treatment, which is what it's all about, is what Tony talked about, and we could keep them out of jail and keep them in treatment. It's just a suggestion, if you're going to be thinking about all of this, for the future. Because what day are we on? This morning, I didn't finish till 12:30. I had 35 people in custody on warrants, and I guarantee that at least 25 of them could have gone through a different process. And that's where we ought to be going, if we really care about reducing the population of the jail and helping people.
Can I add to that?
Looking at the report, if you notice on the very bottom from the referring sources, so they listed all of the agencies and police departments that took folks there. For probation and parole, there was only one of each. And that means, to speak to your point, Judge Manley, is that once you're already criminally justice involved, or you're on probation or parole, you're going straight to jail, regardless of whether you're under the influence of alcohol or whether you're under the influence of substance abuse, you're going back to jail. In the end, and then you're going to have to see a judge or have to wait for your parole hold to be lifted in order to, figure out what, to either be released or get assigned to some type of treatment. That's just something that I noticed.
You good? No, you don't have to. I'm just looking, your light's still on, so.
Oh, I'm sorry.
No,
I
that's
don't-
okay.
I don't know the
just was
rules.
waiting for you to, that's okay. You don't need rules. You're Judge Manley. Everybody else here okay? So I just want to talk through then some concrete next steps. So one is I'm excited to hear about the medical detox beds and those additional 8 beds. And it would be great if we just could get, as you start to know better, a timeline as to when those beds will be coming online. And you may know some of them, but not all of them at this point. So I'd be interested in knowing that. As it relates to the facility taking in patients who have mental health issues, I think it would be good to have to agendize another discussion to really take a look at the facility and the options that you're considering, and perhaps we could just do that at the next meeting. I understand the point you're raising around there's a combination of issues relative to licensure. How do you know what someone's on? And then how do you triage them to the appropriate location? So one of the things I'm going to really want to understand is where would the sobering station fit on that triage map? And then if we could take a look at 2 additional issues that Judge Manley raised, and one would be to take a look at this issue relative to warrants. I think that, and I would ask Judge Manley just to, if you wouldn't mind refining that a little bit in writing about who you think we should be considered for eligibility. And then the second is whether or not we're going to be prepared to take warm handoffs from the courts. Because I think that's actually a really, really good idea in terms of making sure people actually get connected to services. Did I leave anything out? Pablo? Yeah, thank you.
Yeah, just something that's coming to mind when we're looking at, and I know that, and I completely agree with what Judge Manley is saying. I completely agree with the fact that there's dual diagnosis. There's folks that are doing both. What I'm concerned about is taking something that's working for a specific group of folks and then adding to it a component that is already packed. So all of our, we don't have enough drug and alcohol beds, and adding 8 more to a problem on the front end is not going to be a solution. What we're going to do is create another place and another entity or another sobering station that's not going to be able to handle, because we're adding the substance abuse portion to it. And I think that's I just want to make that clear.
Clear to the members of the commission and also all of the public, what we're describing would not be married to the sobering center. They would be 2 completely different entities, just because of what the licensing requirements would be. So it's not one giant room that's going to do everything.
Right.
That wouldn't be a good thing for clients. It's really having those that are inebriated and those that have a variety of different issues. And I think in terms of where we're headed, actually Supervisor Chavez has asked us to provide her with our current capacity. We're expanding exponentially our substance use services. We are now providing medication-assisted treatment. We've been assisting in the emergency department at Valley Medical Center, inside custody. We've got lots of new programs to help people come out of jail there. And Bruce and his team are putting together a pretty bold vision of where we're going with substance use. I do think the whole notion of detox has become a big area of focus for us, as Bruce is mentioning, because we are seeing upticks in terms of the need for those services.
Pablo? Okay, and the only other thing I just wanted to add is that, you know, one of the conversations I was having with Bruce is around how we address addiction more broadly. And I think that one of the challenges, you know, we're going to know more once we have these detox beds, but I actually think one of the most significant challenges we have is not knowing the gaps in service yet. I think we're going to get deeper into that with Tony's presentation, but it's a concern I have that really asks the question you do, which is why 8, why not 10, why not 20? And I think what Bruce is saying is it's what we can do now. We know we need more, but I would really like us, as we're continuing to invest in all of these resources, really better understanding how long's the wait list. Is there really one number? Can you really walk up and get help? If you can't, why not? Is it something we want to be able to do? Like, those are more operational questions that I think some of them that Tony's going to hit, but it's an area of concern that I have. But let me just go back and talk about addiction for a minute. When 100 years ago, and I think I was telling Bruce this, I had a conversation with a group of pastors in our community, and they were from a number of different religions, and what they were asking at that time, I was at the city council, and what they were asking for was why, as a city, why as a community, weren't we stepping up the way we are on other issues like domestic violence and doing whole campaigns around prevention, like really diving into prevention around drug abuse and use. And their point, I think the point they were making to me was only that this is such a significant plague in our community, and that we're not, as a community, we're not standing up saying, you know what, we're really going to try to help people who have this addiction, and we're going to really try to address it, and that we're going to do it in a very public way, and that we're going to get deep into our community to respond to it. And I think it's worth us giving some consideration to that, because I was just talking this morning to a couple of superintendents around the challenge we're having with vaping right now. And, you know, I don't know if you saw this, but San Francisco said, okay, we're not letting anybody sell anything in our community that's vaping related. And really, in a way, as I was talking to them, they were so funny. They were like, okay, we have curriculum, and this is what we do now. We have curriculum that's don't drink, don't sexually assault, they just have a list. And they said to me, so do you have more curriculum? And one of them on the phone said, oh yeah, because we don't have enough curriculum. And I thought that's a really good point. Like, the real question is, are we honing our prevention resources in a way that allow us to properly figure out what's the very best way we can help people avoid doing things that long-term get them addicted, and to any number of things. And I raise that because I am interested in getting, not today, but offline, people's feedback about, as a county really takes this big push to look at prevention, how do we do that in a way that doesn't ignore sort of the elephant in the room, which I do think is drug and alcohol addiction. And, you know, I share Scott's concern around meth. You know, I think that as we're looking at some of the biggest challenges we have relative to people's mental health is really closely tied to how long their addictions are and to how strong they are and what they're using. So in any case, I will be bringing something back. I'm going to start with this group just because you're a really diversified group, just to have that conversation. We'll agendize it for a future meeting. All right. So we are going to move on to item 5, and this is our pre-booking diversion center update.
Thank you.
Yeah, thank you very much. Does somebody have a light on over there? Mary, did I miss your light?
I was just going to comment on the rise of anti-stigma campaigns. We have Faces and Voices of Recovery in Southern California, and I was able to meet with the executive director with Momentum and some other agencies about creating more of a county consortium around celebrating recovery. It's not just about, prevention, which is important, but I think part of prevention is recognizing the 23 million people who've successfully achieved long-term recovery. And we don't have enough examples of people coming up stating this is what long-term recovery looks like. And these people are teachers and engineers, and I'd like to see more of that, honestly, because I think that's a more hopeful message.
Yeah, and more to come on that, Mary. Thank you. That's a perfect way to end. Thank you very much. I didn't mean to interrupt you. Thanks, Mayor. Javier?
Good afternoon, Chairperson Cindy Chavez and members of the Reentry Network. Javier Aguirre with Office of Reentry Services. So item 5 is an update on the pre-booking diversion center. As many of you recall, during our many discussions at the Jail Diversion and Behavioral Health Subcommittee, the administration, along with its partners, presented information on pre-booking diversion. The purpose of pre-booking is to divert individuals meeting the specified criteria away from incarceration and sometimes lengthy jail stays into treatment and services in the community. Once an individual is diverted and has completed the requirements of the diversion, the criminal case against the individual would be dismissed. This process supports the county's vision to decrease over-reliance on jail bookings to better utilize community resources as effective interventions. The Board of Supervisors approved funding to convert and utilize a portion of the Reentry Resource Center to house the Pre-Booking Diversion Center. And since August 2018, Office of Reentry Services, in partnership with Facilities and Fleet, Behavioral Health Services, and Pretrial Services, completed the design and ordered the furniture. There is a typo on the ledge file on the package 15. Instead of August 2019, it should say 2018, so it's almost a year that we've been working with FAF. FAF is now waiting to receive the final permits from the planning department to proceed with construction, and our estimated completion is the end of August 2019. So the idea is to convert one of our conference room into the pre-booking diversion with a separate entrance for law enforcement. Behavioral Health Services and Pretrial Services and Office of Reentry Services submitted position requests as part of the fiscal year 1920 recommended budget process. However, these positions were not included in the county executive's recommended budget and not included in the final budget approved by the board on Friday of last week. But when the center is ready and program is ready to start, we will request the positions. Currently, the administration, in collaboration with pretrial, is completing the list of offenses that will be part of the criteria, receiving final input from San Jose PD and others, with the final approval from the district attorney. And with that, I'm open for questions or comments.
Great, thank you. Thanks for the reminder. You need those staff people. Good job. Any comments or feedback? No? Do you, Erin? Go ahead.
Just a quick one, Javier. When this is done and that you kind of have a booking protocol, so will law enforcement supposed to know where clients are supposed to go, whether it's to the diversion center or to jail to be booked, or is it going to be a handoff? How's that part going to happen?
So we are working along with behavioral health to develop a brochure for law enforcement agencies to then know that there's going to be literally 3 doors at the reentry center for law enforcement to drop off. Folks at the sobering center, the mental health urgent center, and then the pre-booking diversion. So once we have all that established, just what we did with the sobering center, we went to all the law enforcement agencies, offered to do briefings at their various times to present to the law enforcement agencies. With different numbers, there'll be some numbers for each of the units that they could call in advance to see if that individual fits that criteria.
Judge Manley?
Javier, I realize you don't have the staff, but you have the proposal, and then you would get the staff. What is the number of individuals you can process per day?
So we're looking at the timing of the booking. So if I recall, pretrial was looking at between 3 a.m. to 8 a.m. time of the bookings, and then in the afternoons. So we did a calculation of all the bookings that came in that would fit in the misdemeanors. We are revamping that data request to see what the numbers are. But we feel that with the 2 pretrial officers, the clinicians, and a community worker, we could serve the clients, not necessarily 24 hours a day, but we will start with a component of mostly the weekends and some evening hours.
But what number a day? 50, 100?
So we're still working with pretrial to identify the
Okay,
exact number.
thank you.
The only other thing I just wanted to highlight for all of you is that within the reentry center, especially as we're relating to mental health, I want to make sure we have family finding as a component of that, because many of the young adults that we have in custody that have mental illness, they have families that are still really connected to wanting to provide services for them and to be part of their lives. And we keep talking about how we're going to strengthen families, and this to me is such a core component of how we strengthen families, which is reconnect people when they've been disconnected. So So I just want to put that on I'll be looking through all my plans to see where those are. Yes, Judge Manley, your light.
I just wanted to strongly support your statement. I get maybe $80, $100 letters a week from family, and there certainly are family for many individuals who feel totally cut off once a person enters our criminal justice system. So it's a really good idea and an important concept, I think.
In the interim, I'll just remind all of you that if you do have families who need help, we just have done a contract. Actually, you just redid the contract, Tony, with NAMI, and NAMI will provide support and classes helping people understand how to communicate and get acclimated to figuring out how to reconnect with those family members. And it's a small contract. We're really just trying this out, but as often as possible, we're trying to connect people with their families.
If I may add too on the family finding, as part of the CAPS, the Community Awaiting Placement program that we will implement, we're going to pilot a family finding component. So we're working closely with the Ombuds program through the CEO's office. They have mediators that when our staff goes into custody to meet with the CAPS eligible clients, one of the questions is, are they willing to reconnect with their families? And we have a form and a referral that will go directly to the Ombuds program.
Great.
And the Ombuds program will then facilitate that conversation when the individual is out in the community.
That's great. And really one other component of family finding that we're using in foster care, so this is just something we learned the other day, is that in the county of Los Angeles, some of their areas are able to take children who would be put normally into a foster care system, and they're placing them with family members outside of the parents or the primary custodian that they've been removed from, and they're placing between 80 and 90% of children with family members and not in foster care. And that's really tremendous. And that's partly why I want to look at this system across our systems, because, like I said, we keep talking about how we're supposed to be reinforcing the strength of families, and then we introduce institutions instead of helping people be connected and responsible for their family members. Erin?
I just wanted to say I'm a little struck by, and I understand why it can't start 24/7, but there's a significant impact on people's lives, whether they're going to go to the pre-booking because it's during the right hours, and if they don't and they end up getting booked into jail. And it just feels like ultimately we're significant impact from that in different trajectories for people's lives. So I just think we need to really look at, when possible, how do we make this a booking protocol and it's available for all lower level offenders?
Good, thank you. Any other comments on this item? If not, I'm going to move then to our last item on our agenda, and this is item 6, and this is a criminal justice and mental health system assessment. And Tony, I'm going to hand this over to you.
So I think they're getting the PowerPoint up. This is Roberta Chambers. Both of these wonderful people are PhDs. And Roberta is a clinical psychologist who assisted us with our older adult redesign. And Artavan, I will never say your last name correctly, I'm sorry, is also someone with a doctorate whose area of expertise is forensic health, mental health, behavioral health. And I asked them to come in as outsiders and take a deep dive to look at our current jail diversion post-justice services system and let us know what's working and how we could improve. And what they're going to be providing to everyone today is a summary of their findings and their recommendations. And the assessment is going to be updated, I think, after today's meeting, and then we'll be posting the assessment so that everyone can see the complete report. So thank you. It's up to you guys.
I think, yes, it's on. Well, thank you for taking the time to receive this report. We're very excited to share this with you. A couple of kind of comments before I turn it over to Artavan. The first is that I think we know across the nation, both here in Santa Clara and California and across the nation, that there is an overrepresentation of people with serious mental illness in the justice system, and that people with serious mental illness are more likely to become justice involved, and then once they're involved in the justice system, they're more likely to stay involved throughout the entire process. And so there are efforts across the nation to identify diversion options. We know that Santa Clara has been a leader both here in California as well as nationally, and that there are numerous efforts and initiatives to try to address this issue. We were really asked to think about, okay, given that people with serious mental illness are still in and out of the jail, what more can we do? How can we understand the underlying dynamics and really get to the place of really how can we promote diversion at every opportunity when it's both safe and appropriate to do so. We really started this with a couple of premises that we wanted to just kind of put on the table as our assumptions. One is that the justice-involved population almost has like a three-dimensional axis of there's what's going on with their mental health issues, there's what's going on with substance use, and then there's what's going on with criminogenic risk and need. And understanding the interplay between those three different risk and need profiles is a part of what's important in any community to really address the issue at hand, as well as that interplay of assessments and risk and needs profiles really should inform not only clinical placement, but also legal determinations of who's diverted at what point, that the justice system by definition has graduated sanctions and incentives, and to use the information from assessments to really leverage that. I think I'm going to turn it over to Artavan at this point to go into the kind of the more assessment things.
And I'm going to check to see if, yes, this is on. All right, great. So the purpose of the assessment was really fourfold. We wanted to assess and identify how individuals with serious mental illness are identified and processed through the detention and adjudication process. We wanted to look at the extent to which justice and behavioral health partners are assessing individuals' risks and needs, look at the treatment capacity, availability, and need for individuals in Santa Clara County, and also opportunities throughout the system to provide services and appropriate and to divert appropriate individuals away from the criminal justice system. So those were sort of the key overlaying purposes of the assessment. We conducted literature review and benchmarking research across California counties and nationally, and also interviewed 33 partners across the justice system and behavioral health systems. One limitation of the assessment is that we were unable to attain quantitative data to define the target populations and approximate treatment capacity, and that was largely due to privacy concerns and just inability to attain those data for those reasons. I won't go through this too much because I think folks are pretty familiar with the sequential intercept model, and here's a map that's also in your packet that we're happy to discuss if you have any questions at the end of our presentation. It's sort of color-coded to suggest the types of services, recommended services, et cetera. And again, we're happy to discuss that in detail at the end if you have any questions about it.
Quickly, assume that we're not all doctors, and just explain really quickly what the intercept model is.
Oh, of course.
Yeah.
Sorry, I just didn't. Yes.
No, please.
Yeah, so the sequential intercept model is a tool that was developed in the 2000s, and it's often used for planning processes to identify and map justice and behavioral health system processes, and to identify sort of what the resources are that are available across certain intercepts, what the different processes that take place, and identify opportunities for additional resources and for opportunities for diversion. The intercepts are named just basically based in a sort of world that doesn't truly exist, where it would be a linear relationship in the justice system, right? But it really just takes you from the community and law enforcement through the booking and court processes, and then through reentry and reentry services, and looking at it throughout those steps to see where these opportunities are and what things map really what it looks like in Santa Clara County today. And so that's how we use the sequential intercept map to inform the assessment and inform the findings. Absolutely. So I'll jump into the findings from intercepts 0 and 1. And so this would include the time period that is the front end of the system before anybody hit a jail, right? And so the findings just demonstrated, there's three main ways that law enforcement are identifying individuals with serious mental illness in the field. And so that could be through dispatch, that could be through sort of erratic behavior in their interaction with individuals in the field, and then there's a number of individuals where they've made consistent contact with, over time, previously identified mental health needs, right? At this point, law enforcement sort of expressed there's three main options, right? You can, arrest, divert to services, or in some cases when appropriate, leave people in the community. And our assessment finding and conversations with law enforcement and other folks really highlighted that training has really supported law enforcement in being able to identify individuals with serious mental illness in the field. And at the same time, there is currently limited sort of structured decision-making happening across the county around decisions around when to divert to services, when to arrest. And that is something that we spoke with and law enforcement noted. And one of the things they noted is the real excitement for the implementation of PERT as that kicks off, and the implementation of the community assessment tool to support some of that structured decision-making in the field with a clinician. It's also noteworthy that the mobile crisis response teams are available right now currently in appropriate situations and appropriate emergency situations for law enforcement, and at this point can respond 24/7. So I think that's one important note at this time. Yeah. Based on the findings that came out of the Intercepts 0 and 1, and I think it's really relevant to a lot of the conversations that we've been hearing in the room today, we had a recommendation to develop more alternative drop-off locations for law enforcement across the counties. These could include unlicensed low-barrier facilities such as multi-service drop-in centers or warming centers, where these can be comfortable spaces for people with high needs, where they can be connected to services, but there's that kind of lack of the barrier of the licensing and specific criteria people would need to meet to achieve those services. We also recommended the forensic mental health urgent care that was sort of talked about, I think, in part today, which would be similar to a standard mental health urgent care, but have clinical staff with specialized training to work with individuals with justice involvement. We also suggest incorporating decision-making tools countywide, and we know that's going to be kicked off soon here with some local jurisdictions, really thinking about countywide how to implement those tools, criteria, and training for when to transport to pre-arrest diversion options. Intercepts 2 and 3 encompass sort of the time spent in jail and the court process. We found that there's 3 main ways that individuals are identified with serious mental illness in the jail. During the booking process, the law enforcement officer may have identified that individual and put it on the booking sheet, and so that's one way. Then also during the pre-booking process, folks are identified by a deputy, and then also an assessment is conducted by a nurse within the jail for everybody, and those individuals are able to identify individuals with mental health needs in the jail. Individuals who are identified as gravely disabled who require residential inpatient treatment are housed in Unit 8A, and then there's also subacute services for individuals, or services for individuals with subacute needs to receive services through specialized management units in the jail. For folks in general POP and in some max security, they can also receive services through custody house as well. There's 4 main ways that people with serious mental illness who have criminal cases are processed. There's some folks are deemed incompetent to stand trial. There's the new AB 1810 opportunity for diversion, and then there's processing through the treatment court and processing through traditional courts. The treatment courts and AB 1810 diversion provide a really important opportunity to divert folks from traditional criminal justice processing, and Santa Clara County has really been a leader and a national model for mental health treatment courts, as I'm sure all you know. One of the things that folks talked about were really highlighting the way this court has supported individuals with serious mental illness in the community, and also highlighted that there is that it's really bumping up at capacity at this point, because there doesn't seem to be a clear documented eligibility criteria for who would be referred to the court, and as a result, there are some populations who may not be the appropriate target population that are being served through the county's mental health treatment court. One other key finding of note from partners was that individuals spend long periods of time in jail awaiting competency restoration. I think that's well-known statewide issue across counties, and there's work being done to address that already in the county. So one of the recommendations was to implement the community-based competency restoration, and also consider implementing jail-based competency restoration, and then also developing eligibility criteria for the referral to treatment court and pretrial AB 1810 diversion. Intercepts 4 and 5 really look at reentry and the services that are available in the community. And there's a wide and expanding array of services that are available for the justice-involved population in Santa Clara County with serious mental illness. And also, there has been a clear effort to create collaborative reentry services within this county. I think that's very clear in talking to all the partners. There are very strong relationships being forged, and people are all seeking to sort of solve the issue together that you know, really is in the room and been talked about throughout today. CAPS is a really good example of one of the programs that's come out of that. And it's a really good example of this collaboration that's taken place over the past couple years. However, even within CAPS, we do see some opportunities for improving decision-making processes, especially around who is being released at what, or yeah, we'll talk about that in just a minute. And then finally, one key finding from this area was that active substance abuse really impacts the ability of consumers to connect to treatment when beds are available. I know you all have discussed that today and at length in this county as an issue to address, and we have some recommendations around that as well. So the first recommendation we have in this intercept is really to consider clearly defining and documenting CAPS decision-making processes, including eligibility criteria and the criteria that are used to determine who will be released, sort of when that JAC list is being reviewed each week. And then we also have the recommendation to consider attaching detox treatment beds to treatment facilities for individuals with the serious mental illness so that they can first go to treatment and then be immediately connected to the treatment and not have any gap in that service, and they're just right co-located together. And we also recommended considering adding medical detox as a treatment option. These were sort of the findings as we talked through each sort of intercept on the ground, but there were a set of recommendations that really fit together and a set of findings that Roberta will talk about more across the system.
So the first one really has to do with the use of structured decision-making. And if you kind of operate from the premise that justice-involved individuals with serious mental illness are a heterogeneous group, then we can know that there are talented, well-trained, really passionate and committed folks throughout the system in all of the departments and CBO partners who are using a variety of tools to identify individuals with SMI, assess them, and then determine and support decision-making around treatment and the legal process. However, there are a couple of things that get in the way of that being really being the most successful. The first one is on this slide and the second one is on the next slide. So the first one is we're making a recommendation to consider using a standardized battery of assessments so that when people are talking about either any risk and need profile, whether it's substance use, mental health, or justice, that they're talking the same language about the same things with the same types of scores, and then to use that standardized battery to support decision making. So similar when you go into an ER, you see a triage nurse, and they take some vitals, and then they determine kind of where you are in the queue. It's a similar type of idea of use the assessments to determine then kind of where that person may go across the treatment and legal continuum. And then to document the eligibility criteria across the legal processes so that you really do get the benefit of the new and expanding options of AB 1810 and the pretrial diversion. The next one has to do with data and information sharing. So even with a standardized battery of assessments and some agreements around eligibility criteria, there is still the issue that sharing information both at the individual level in terms of, hey, I'm a provider and I'm receiving somebody kind of either from the treatment court or through one of the options where people may be referred post-release from jail, it's very hard to share information easily about what that person may be experiencing, what their history is, and what might be the most useful in terms of that provider, both maintaining safety and supporting that person's recovery. Additionally, at the systems level, it's hard to monitor kind of how this is going, what capacity might be needed, and where you're having kind of the most benefit above an individual program level because of some of the data sharing issues. So our recommendations really kind of are at both of those places, at the individual case planning level and at the systems level, to think about ways to increase kind of as privacy restrictions allow you to, but look for ways to share information to support individuals across kind of the different agencies we're talking about, as well as at the systems level. This could be things like data system linkage. It could be things like asking a consumer at the very beginning to sign a shared release of information across all the justice and treatment partners. We also suggest some sort of collaborative case planning or a multidisciplinary forensic team, which has been a model used in other, across California and I think nationally, to really allow people the chance to talk about kind of who's coming through and what are the best options. That does happen here, but it doesn't happen kind of probably broad-based enough or as consistently enough to really kind of get the amount of benefit that you'd like, that you probably like. The next one is that there is, the people who aren't as successful in treatment court appear to be kind of in and out because they're not completing treatment, even when it's mandated. Our thinking is really to suggest more intentional use of the graduated incentives and sanctions that are present within the justice system, whereby when somebody does well, they experience additional freedom. With that freedom comes responsibility. And then to reserve those sanctions where they will be of benefit to encourage compliance. And then to think about, there's a kind of a lot of, I don't know, it's kind of colloquial at this point, but they're not ready, and because there are limited resources, I think there is some hesitation to use resources for somebody who might not be standing up and saying, hey, pick me, I'm ready, I'll do whatever you say. And so there are some ways to train counseling staff and different treatment and legal staff around how to use motivational interviewing, motivational enhancement, stages of changes, techniques to really help somebody develop readiness for change, as opposed to expecting them to be ready before treatment or whatnot is provided. These are things, I do want to say, these are things that are currently present in the county. We're suggesting a more broad implementation of them and rollout across all of the partners. We don't want to suggest that this isn't already happening, but more to maximize the benefits that would be available. I think this is the final recommendation that we have across the system has to do with transitional and permanent supportive housing. And in some ways, Santa Clara is a victim of its own success in that you've been a national leader in permanent supportive housing. And many of the resources, both at the federal level and locally, have really been focused on permanent supportive housing for people with serious mental illness who are also then become justice involved. Our recommendation is to bring back some portion of transitional housing so that there's more flexibility to get people housed with more agility kind of when they need it, because there's such a lack of permanent supportive housing for anybody, even folks who are justice involved. And so to see if there isn't a way, and that Los Angeles and some other counties have found ways to kind of structure those housing and leasing arrangements to be able to make housing available much more readily when somebody's exiting jail. And I think we know, I don't think it would come as any surprise here that having housing is one of the things that does support the ability to engage in treatment and kind of comply with whatever those terms and conditions of release may be, and the recommendations from treatment providers. At that point, I think Ardavan and I will pause and kind of ask for questions or discussion.
Thank you very much. I'm going to start on this side and see if there are any questions or feedback. No? Judge Manley?
I don't know if I pushed the right button, but I tried. Okay. You know, I don't know how much time we have here, and I don't want to monopolize this, but.
Go ahead.
I want to go back to slide 10, if we could look at that. I'll try and do this by slides. Well, that's slide 10. Maybe I'm on the wrong slide. No, see, I have pages. I don't get these. It says 10 recommendations. Okay. It is the next slide, 12. I'm sorry.
I'm not sure.
You're on the right page right now.
Am I on the right one now?
Yeah, that was.
Okay, thank you.
Good job.
Yeah. Well, all right. Now, if you would move to what on my put out is slide 12. Can you do that? All right. Now, I just, in behalf of my presiding judge, who, by the way, I forgot to apologize, could not be here, although she wanted to, and Judge Zucker, who supervises criminal. When you say develop eligibility criteria for referral to the treatment court and pretrial AB 1810 diversion, number one, we do have a criteria for treatment court, and we have had it for years. As to 1810, the criteria are statutory. You don't develop anything. It is in statute. Diversion is in the discretion of each and every judge who reviews the case. All right? Eligibility is defined by statute. Suitability is defined as completely discretionary with the judge. And so I strongly urge that we not start to try and develop eligibility criteria for those two. The next thing is on the next point, consider jail-based competency restoration. I strongly oppose this. This is exactly what the legislature and the governor have done recently in trying to avoid the challenges and being held in contempt by state court judges to create a restoration program in a jail and put, well, I call it cherry picking, but put the people that they quickly think they can move in and out to the state hospital or back to court in the jail. Jail is not therapeutic. I don't think anyone here who understands our jail is going to tell me or anyone the traumatization of individuals in the jail who are mentally ill. You increase that trauma again and again and again. And the way jail restoration works is the restoration part of the process is during work days, 5 days a week. Nights, weekends, you are treated like an inmate. And so these programs to me not only do not work, there's no proof they work, and number two, I think it works against the whole idea of diversion. Because all you will do is fill those jails that have room, like Alameda County, Santa Rita, Kern County, they have room, and you'll just fill them with mentally ill offenders who are incompetent to stand trial. And to me, that's simply, why don't we build more jails or more hospitals for them? See? So I'm totally, I just want to go on record about that. Next, if we would go to page 13. I think what you make very good points. The most important one is that treatment capacity is an issue. In my view, we will never be able to face this issue and overcome it until we can figure out how many people are in treatment at any one time in all the programs that we have. And that, to me, is something, Supervisor, we've talked about. I know you're busy. Since 2016. Since 2016. So we are going on 3 years into 4 years of talking about that. I think we need to bring that to an end. We need to know what the capacity is and what we need. A statement was made, and I guarantee you that in my work, the number of referrals I receive, both diversion and non-diversion, by diversion I mean 1810 diversion, is increased dramatically. Not because we don't know what to do or because they're not assessed properly, but because there's nowhere to place them. All right? And that is why the JAC list remains in effect. It should be gone. You make a very good point, and I want to emphasize it again and again and again, that substance abuse gets in the way of engaging people, re-engaging them, keeping them in treatment. And we've got to focus on that. Going to page 14, I strongly support your second point, that detox beds should be a part of any kind of treatment work with the mentally ill population. And they should be there, and we should spend the money to do it and make it work. And I think medical detox as a treatment option, I cannot tell you, and I know I'm getting overwrought, and I should just simply take a deep breath as I tell my clients. But I cannot tell you. Every day I see people who are just falling apart in front of me out of custody, where there's nowhere to go except jail. And when you say, medical is so complex, and Bruce is right, I would never, dispute Bruce is an expert on these things. It may be an expensive model, but so is jail. And what no one wants to admit is all the people I see detox in the jail under horrible conditions, and they don't come out any better. And there is a better way to do it. And so I just strongly urge that in this work, we pay attention to that. Finally, and I'm just going to suggest, Supervisor, we have been down this road. You made a statement that I most strongly support. Allocate resources for transitional housing. And I just want to read to you something. I do a lot of work with my colleagues in Los Angeles because I strongly support what they're doing down there. And this is just, it's a very brief quote. I won't take much time. And I know Key will be upset with me, but I'm used to taking abuse. All right. This is a statement from their leadership, one of their leadership. All right. We need I realize Los Angeles is an empire. All right. So the numbers are very large. The statement is this: we need 5,000 beds now. We need another 5,000 beds next month and another 5,000 beds the next month. Not apartments, beds. Okay? So the urgency to me to do something, Supervisor Chavez and I joined forces once, many years ago, I think it was 2016, and simply proposed, let's get 200 more THU beds, transitional house beds with different rules. We have to, I think, all of us, address this as an urgent problem. You've done a wonderful job in laying things out. I mean, I don't agree with all of them, but I agree with 99% other than the ones I say that, I can't because of we have to follow the statutes. But what's lacking in here, and I guess you're not allowed to say it, I think there's an urgency. What this statement from Los Angeles is when they're really trying to make some changes. They are so far behind. They're touching so few of the people who need it. I think we ought to adopt 3 rules, if we could. Urgency, number 1, that we all take this as an urgent problem, immediate, now. Number 2, that we have deadlines. We don't ask this. I asked this question about capacity in 2016. It's now 2019. I mean, let's find out now. Let's set a deadline and not change it. And finally, let's hold ourselves accountable. If we can't change this and make some decisions as a group that the board will support, then we should not keep meeting and talking about issues that we've been over again and again. Thank you.
Really, that's it? Are you dropping the mic? All right. Oh. Are there any other comments or feedback on this side? Yeah. Key.
Good afternoon. In your assessment, the presentation here is sort of focused on the system, the points of interaction with different parts of our system. In the assessment, does it sort of go into the specific needs or categorizes the needs and different levels of need of this sort of target population?
So, Key, the answer is going to be both yes and no. The yes is that one of the premises that we started with is that really this idea that if you have somebody who's having frequent justice contact but has a low criminogenic risk profile, that really you want to pull those people out of this population and get them into a different system so that you really are reserving the justice resources for the folks who need it most. And then as you think about kind of where you might use different ways to either get people out or keep people in the justice system for different reasons that you're using assessment data. The one limitation that Artavan mentioned was the inability to get individual level identifiable data about the population, and that does limit our ability to describe them in the level of detail that you might be seeking, as well as to approximate treatment capacity needs.
Okay. So maybe that sort of answers the second question I had, which is sort of around, because there are some recommendations around individuals' temporary, interim, and permanent housing needs. I wonder to what extent you were able to capture sort of the housing homelessness status of the target population, and then two, sort of the permanent housing, sort of outcomes and retention related to the various programs that are sort of in existence now.
Yeah, I mean, I think one of the things that was really useful when we did the adult redesign is we were able to go by level of care and how much of what for whom was needed. And on this one, we really, because of some of the limitations, took a different approach in terms of let's look at this from more of a process and structural perspective, because we don't have at our fingertips the information that would help us replicate that.
Okay.
That being said, however, I do believe that what is here is useful in a different way.
Sure. Yeah. And just the last question is sort of based on your conversations with LA, other counties, and sort of your assessment here. Assuming we're talking about people with a serious mental illness, a lot of involvement with the criminal justice system, I would say to a man or woman, we're talking about people who are homeless or will be homeless or were homeless when they came into a jail. So what is the sort of effectiveness of temporary housing programs, 4 to 6 months, in moving people into permanent housing and sort of without sort of long-term subsidies and ongoing supportive services?
I think you're probably asking a question that is sort of unanswerable today, if that makes sense, because you're getting at the heart of the issue is, so we're recommending that you do something that is temporary, that will help people without the promise of that golden ticket on the back end. And we are suggesting that you still do that, at least for now. We didn't get into what the what the options are on the back end for permanent supportive housing. Every jurisdiction we talked to had plans in place and was able to talk about the different linkages that they've set up, and they all also struggle with it. Knowing that you have the most impacted housing market and housing development crisis in the state, you probably will have the hardest time. That being said, I think what we heard is even with the lack of permanent supportive housing, that transitional housing does help transition people out of the justice system and give them every opportunity to stay out.
Okay, thank you.
When combined with treatment.
Damon and then Pablo.
Sure. In Damon Silver from the Public Defender's Office, and looking at this may be more of a proposal rather than a question, but I think there's a question wrapped up in here, which is, looking at the zero intercept opportunity, the community opportunity, and thinking about kind of a no entry model, it immediately triggers for me this idea that many of the criminal justice partners now have outreach components or units in our office. I know the district attorney does. I believe that probation is launching theirs. The public defender has, at least at this point, a single individual. And I don't want to speak for the other offices, but certainly what we've tried to do is carve out an area of service directed towards homeless population and how we can become an interface. And I guess my question is part of this analysis considering how we kind of leverage these outreach units in our offices and how we marry it as a portal to entry of services so that we don't have to wait for people actually to go into the system. I'll give just a quick example, which is our community outreach attorney has tried to focus on high concentration homeless camps, and especially since the closure of the jungle, it's been more challenging to find exactly where people are and how we can get out there and serve them. And one of the things we do when we go out and serve them is talk to them about, do they have outstanding warrants? What kind of barriers do they have to housing? So how can we address, for instance, record clearance services to remove those barriers in housing? So we're in a process of ideally building some credibility with them And now organizationally, we don't have a lot of training in motivational interviewing. I know that probation certainly does, but that's, for instance, an area I'd be interested in leveraging our community outreach attorney to learn, and our post-conviction outreach unit to learn those skills, but also begin kind of coordinating with behavioral health to think of a path where, when we're in the community, how do we hook people up before they ever get into the system?
Yeah, I just want to comment on that just briefly to say I think that that's one of the great opportunities to think about implementation of some of the recommendations, right? And if you think about adding some of the service centers and adding additional diversion opportunities, just thinking about how the county partners and law enforcement can work together to develop some of the processes for linking folks.
Thank you. Pablo?
Mr. Silva, I want to speak to your point. In order to effectively do what you're doing with outreach, strongly consider working with folks that are recently transitioning from homelessness, because they know where those places are at. While they're maybe moving in a different direction, there's still strong contact. They're still utilizing that resource is going to be imperative. The next, just going back to the last conversation, is that I work with doing employment for folks that are, we serve a lot of the same clients, folks that are involved in THUs, SLEs and whatnot, the temporary housing units. I think we need to start considering a lot of the time the support that we're getting from folks that are being successful in treatment or in their utilizing their THUs in a positive way. The same time where we're cutting people off is the same time where life is starting to hit them. So things like restitution is starting to kick in. They're getting letters from, I don't know, their state fines, child support. So the limited resources that we are using towards giving individuals employment, for example, is being garnished right around the same time that the support is being taken away from them from their housing. So we have to do a better job of figuring out how we're going to help them transition from temporary housing and create opportunities for them to be more successful while life is starting to kind of fall into place, because you're getting better and you're starting to finally address some of the issues that you've neglected for a long time. And at that exact moment is when we're saying, okay, you have 30 days left in your THU, and panic mode kicks in. And then we wonder why people are disengaging from treatment. Just a thought.
So, so I just want to make a couple of broad comments, and then, go ahead, Chief.
Yeah, I just had a question on slide 10. Oh, good.
Which slide?
That first bullet about the multi-service drop-in center. Can you give a couple of examples of what you're talking about?
Yeah, so in terms of a multi-service center, it's really just looking at a place where police could take somebody where it didn't require that they had a mental illness, it didn't require that they get medical clearance for something. It really is just a place, usually it has like showers, a telephone, some food, and it's really just a drop-in center where police know, like, hey, I don't necessarily need to arrest this person. They're not going to meet the threshold for needing to go to a sobering station or to go to an urgent care center for mental health. But I am uncomfortable leaving them where they are, right? Because of the public nuisance, because of the relationship with whatever's going on with the business. And so this is intended to be that. A number of communities, including Contra Costa County, they have renamed them to be care centers, but it usually has some kind of rehab level type staff there who can do some light service coordination, engagement, and kind of welcome people into the beginning of what's hopefully their recovery without having to have that journey include a booking.
So, first of all, thank you for the report, and just a couple of observations that I wanted to make. I think that we can't really have this conversation in a meaningful way without looking at numbers. And so I am really just looking at your office now and you, Miguel, to say that whatever barriers exist, like if we can't get numbers, it's literally it becomes of less and less value to keep having the conversation. And I think that even coming up with methods and strategies, absent having the numbers, it's hard to know whether or not what we're talking about is a good idea or not a good idea. I think we're going to be in a situation in the next couple of years where we're going to start losing resources. And what that means to me is that we're going to really have to understand what are those strategies that we're employing that have the longest term meaningful outcome. And so I don't know how to do this. I really don't, because I feel like we've talked about it. We've talked about it in public meetings. We've made referrals. I really don't know what else to do to drill down, but I would really like your insight, just to give you some time to think about that. And then perhaps we can have a meeting and then have a conversation about how we get there very publicly in a very transparent way.
Sure, and just to have some clarity, there's so many numbers out there. Are you looking for the numbers on capacity? Is that the biggest concern?
I want to understand what our current capacity is, what our current wait times are for each of those, and then very concretely, at every level of the department, how do people access the resource? Just how do people get in? Very simply, I think that so let me just pause there and say that part of the reason I'm so concerned about this is that I just want to use the housing as an example, which I think is really challenging in our county. But here's what our dilemma is. For generations, we have used public dollars to build two kinds of housing. Well, really three kinds, but two kinds that are acceptable. Low-income senior housing, because it's the least offensive thing we can put in a neighborhood, and a bunch of moderate housing. And so we have now a very tight, small resource to build permanent supportive housing. We have a bunch in pipeline, but we've housed less than 500 people, maybe around 500 or 1,000 in our permanent supportive housing. Well, let me just say this, we need to get minimum to about 5,000 just to be above water. And then we're getting feedback to build transitional housing, which requires the same amount of time, the same amount of money, but it's not permanent. And that brings us back to the point that Pablo raised, which is great. We have more poor people who can stay in places for shorter periods of time. And I think absent us being able to say, the nut we're trying to crack is X. On the housing, on the homelessness, we know that we have 8,000 people approximately that are unsheltered. My guess is a whole bunch of them are the same people we're having a conversation about, but we don't know that. It would be good to know so that we can be more strategic with those assets and resources. If we get into the transitional housing business, we're going to look, frankly, LA is a great example to me. They are doing a lot of really great work, but they have a whole part of their downtown now that's become lawless, dangerous, and unhealthy because there's no way to manage the sheer volume of homeless people they have. And the volume of that, subset of that are mentally ill, and the subset of that are just addicted to drugs and alcohol, it is a mess. So what I'm really trying to figure out is if I understand if I can get my arms around the numbers, I think we can provide much more concrete support to our staff in terms of accomplishing what they most want to accomplish. So whatever it takes, and if we just have to crack that nut. And let me just say, it's not just been Judge Manley. This has been the very first time we had a meeting, the very first meeting we had with the subcommittee after Michael Tyree's death. The question about capacity and need was raised by Aaron. And Aaron asked us, why are we having conversations about all this if we don't have the numbers and the math to talk about it? Then I thought, we're still kind of new at this. Let's give ourselves a chance. But that's really been more than 2 years. And I feel really bad about that. And I also feel bad because I think the perspectives, like I'm nervous about even starting up these 3 centers that we're going to drop people off at, because I feel like there's such a lot of pressure on us to act that we're acting in ways that don't align with goals and missions that we've already set. And one example on the 3 little locations is we have a reentry center that we have an opportunity right now, right here, to rebuild, to have it have a bigger footprint, to have those 3 doors, easy to ingress and egress, and to even have a drop-off center and potentially housing. And this is actually where I'm having an argument with some of my colleagues about whether or not it's permanent supportive housing or transitional housing, but proximate to the police station, so it's easy for everybody to access and use, and again, so we can keep people out of being justice involved. I can't prioritize that with the 3 centers and rebuilding the reentry center because I still don't know what is the nut I'm trying to crack. So that's really where my frustration comes in. And I do just want to say this, because whenever an elected official in particular, or Judge Manley, I'm just kidding. You don't act badly most of the time. But whenever we say something critical, it looks like it's a reflection on the staff. And I want to say this, since Tony's come on board, we have massive amounts of resources going into services that we didn't have before, standing up lots and lots of programs. So this isn't to say that we aren't doing good work. It is to say we can't do it blindly. This is just not acceptable, and it's not okay, and we will have no way of understanding when times get tight what we did right and what we did wrong. We just won't know the answer to that. So I'm asking if I can task you with that.
Yeah, absolutely, and I'll talk offline with you to get a better sense of sort of the format. My gut sense is that, there's a lot going on. It's a very complicated issue, and things move quickly. And given its complexity, I think efforts are made to try to provide the information, and it doesn't come across. And so, I think if I can work with you and better understand sort of the format, the way you want to see it, that'll be helpful, that I can then work with the department and get that information, because you can't manage what you don't know. We all know that, and I think that's what I'm hearing you say. And you're trying to make decisions, and so I think we will find a way if once you and I can talk offline.
Well, and actually, RDA, if you could, because they tried to get this information too, I'd be very interested in you sending us what you asked for to just help you with the report. Because my sense is that some of it's very simple and some of it's very dynamic, but nonetheless, I am very interested in getting what your requests were for information, because it was reflected in here that you weren't able to get some of it. And I know some of it's related to particular cases. I'm really more looking at the aggregate. I recognize what those challenges are, but in aggregate, we should still be able to get those numbers. But anyway, what you requested too, and I think we have a couple of referrals that I can give you again that we put forward. So, but again, everybody's really trying hard. We just want to know how far we're paddling. It's hard to know when the river just feels like it's getting higher and higher, and we're still paddling. So, any other comments? Yes, Tony.
Comment. I want to thank both of you and your team for doing this work. And I think that you made recommendations. The county may or may not move on all of those recommendations. And you've had people here on the dais who've challenged and have different points of view. But I think part of having you come in as outsiders who know the work and have talked to many, many counties doing this kind of work, I appreciate that what you provided to us with the information that you could receive, you made a set of recommendations that you thought would be good for our system. And I think now it's up to the department and the county to decide which of these might we put in place. Is it the time to do that? We have so many other things going on. But in terms of bringing your expertise and having a team and really trying to do a considerable dive into our existing system, I just want to thank you for doing that. And I also want to thank you for providing us with recommendations which may or may not be the right fit for Santa Clara County. But I think the role of a consultant is to bring that lens, and then we learn from that and we make decisions. So I just want to say that publicly. And in terms of data, I know that this has been an ongoing issue. I do want to put this on the record because I'm not defending our department, but I am explaining part of what is happening. Right now, we have one very old hanging on EHR. We have HealthLink in County Mental Health, and we're working on substance use with our new NetSmart. And even to gather the data to be able to provide you with what you wanted today, because I've got a whole team working on that. That means there's a lot of work in 3 different systems to try to gather the data that you're asking for. And on behalf of the department and the board supporting the contract, this week has been our go live for NetSmart. The staff have been involved for the last 3 days full time, and they're wildly enthusiastic. And when they show us what's possible, we'll be able point in time to say, these are how many people in this program, this is what the capacity is, this is how long it took for them to be able to have access to care. And it is very, very challenging for us to be able to do that right now. Very challenging. And it's been that way since I walked in the door. So I'm very enthusiastic about having an EHR that will allow us to gather the data at every single level of our system, which we're not able to do today. That's just the reality of what we're dealing with.
Thank you. We have one public speaker, Scott Largent, if you want to come forward.
Thank you, everybody. Last comment before the end of the meeting. I'm not too sure, Mary over there said some pretty interesting things. I really did like you talking about success stories and be able to kind of see if this stuff's working. I do say that a lot, that I need to see more success stories. We have Pablo, of course, who's done really well, and I'd like to congratulate you on your new gig going. And same with Amanda. But that's about it. I do not see any success stories. Now, what I've noticed on Facebook lately is behavioral health is starting to put advertisement up on there. I think that's neat to see that, but why don't we start showing that people actually did get out of poverty, did get off drugs, show where they're at now in the community, what they're doing, and then maybe we should start showing what happens when you continue to use methamphetamines and how bad it gets. You know, maybe we can get that out there so the kiddies won't start using meth. When I was living on the streets, a lot of kids in the neighborhood started hanging out with the homeless and mentally ill, and they all started doing meth. And I thought that was really weird because when I was younger, we never got involved in that type of thing. So it was very strange to see that happening. And, you know, you're existing in a community and everybody's just out to lunch, everybody's getting high, but we allow that to happen here. It's just like it's okay. And where I was living at over near Garden City, every other car is somebody living in a car that is a meth addict. And it's just everywhere. And I feel really bad for law enforcement. The San Jose PD, a lot of the officers that I talk to completely understand what each person is, what their story is, you know, how long they've been on the streets. And that's why I like talking to the officers all the time. I don't just, you know, BS with them all the time. I talk to them about issues of what they're dealing with. You know, I think we can learn a lot from them, but we're not seeing that in these type of meetings. And this was a good meeting today, but I worry that at the end of this, I want to see more. I want to see this stuff pan out. So thank you.
Thank you, everybody. And I do want to just say how much I appreciate. I think these conversations need to be open, transparent, and, you know, as direct as we can be. I think that's helpful to getting us where we want to be. Thank you very much.